We'll make.
So, hello, my name is Dr. Talha. I am a trusted doctor in Nottingham University Hospital. For people who have joined today, we have started this surgical lecture series to cover as much as topic we can, especially related to MRCS Part A exam. For those who are joining us for second time, you know that we record this session as well, and we will send it to you via email, and we'll send you the feedback forms as well. So today the topic we're going to discuss is upper GI surgery, and we have Dr. Waqas, who is a bariatric fellow at Phoenix Health UK. He was very kind enough to join us today and give us this lecture, despite his. I know him. I can imagine he will be really busy, but he joined us today. So thank you for that. So over to you, Mr. Waqas.
Okay, good. So good evening, everyone, and we'll make a quick start. So as I said, I will touch on some of the common topics that are asked in exams, and then you can ask me questions, in the end. And the more questions you ask is probably, it'll obviously help you better, right? So this has stopped working now. Working fine a minute ago. Right. So the first topic we are going to touch on is esophageal cancer, right? And as you know, the incidence of adenocarcinoma is rising all over the world, but still, if a question comes asking you which is the most common cancer of the esophagus, that's SCC, because the esophageal lining is squamous. And SCC is mostly seen in the upper and middle thirds of the esophagus, whereas adenocarcinoma is confined to the lower third of the esophagus most of the time. And we are going to talk about Barrett's in a minute. The adenocarcinoma usually follows from the metaplasia, dysplasia, and neoplasia sequence that you've studied in pathology. So the symptoms of esophageal cancer in most patients would present with dysphagia and weight loss. So whenever you see these two things, especially in an older population, for example, a 50 plus or say a 65-year-old man presenting to surgical outpatients with dysphagia and weight loss over the last 3 or 4 weeks, definitely esophageal cancer is a concern there. And the gold standard investigation for this would be a gastroscopy, right? So in a lot of questions that you will be asked, they would ask, what is the most appropriate investigation in this scenario? And I think the obvious answer for that would be a gastroscopy, and not a barium meal, for example. Especially, in practice as well, if you try to do a barium meal on an obstructed esophagus, that can cause aspiration, as well as the barium is quite thick and can actually obstruct the esophageal lumen. For diagnosis, you will require biopsies, which can be done at the same time when you're doing the gastroscopy. Now, for staging purposes, you require generally a CT thorax, abdomen, pelvis to see whether there is any metastatic disease, and that's true of most or all cancers. But in particular, esophageal cancer also requires a PET scan, as a baseline investigation to determine for any distant metastatic disease. So PET scan is helpful for determining distant metastatic disease. It's not meant for diagnosis of the tumor itself. EUS, EUS, most units will do an EUS to see the local staging, right? So EUS will determine how deeply the tumor is invading, whether it is T1, 2, 3, 4, and it can also determine the local nodal status. So as you know, the staging of the tumor, the T, N, and M status, will then help us decide what treatment options a patient might have. Laparoscopy is only used for lower third tumors and usually in Sievert type 3, which are invading into the gastric cardia. Generally, for true esophageal tumors that are above the OG junction, laparoscopy is not routinely used. So with regards to treatment, any advanced esophageal cancer, and when I say advanced, I mean T2 or, T2 or more. So with the exclusion of T1, T2, T3, T4 tumors, or N1 or N2 tumors, node positive, and tumors that are invading more than T2, so invading more than the muscularis propria, they would require neoadjuvant treatment, right? And the neoadjuvant treatment in esophageal cancer, so now it can be different for both SCC and adenocarcinoma, but can involve chemoradiotherapy or just chemotherapy. So the jury is out for that. So I don't think that can be a question for you. But what you need to remember is that for T2 and positive tumors that you would have determined on EUS and PET scanning, they would require some sort of neoadjuvant therapy, right? And after the neoadjuvant therapy, patients are restaged, the PET scan and is redone to see that they haven't developed any distant metastasis. And if they're still clear and this has worked for them, then they undergo surgery. Most commonly in UK, Ireland, an Ivor-Lewis esophagectomy or two-stage esophagectomy is done. It can be done open. Most units do it open, which involve a upper midline laparotomy and a right-sided thoracotomy through the fifth intercostal space. And it can also be done with a minimally invasive approach, so hybrid, where you do laparoscopic and open chest, or totally minimally invasive, where you do laparoscopic and thoracoscopic. And more recently, some of the units have started doing robotic esophagectomies. The other types of esophagectomies is three-stage or McEwen. Three-stage is done if you need a higher margin, for middle third tumor. Sometimes you cannot achieve a clear margin with Ivor-Lewis, then you have to go to the neck. So it involves a laparotomy, a thoracotomy, as well as a left-sided neck incision. And transhiatal esophagectomy, that is done just through the abdomen. So that involves a laparotomy and a left-sided neck incision. And the mediastinal dissection is done through the hiatus, okay, to the hiatus in the diaphragm. I was going through some of the questions on the EMRCS website, and there were a few questions about the palliative treatment of esophageal cancer. So once patients have metastatic disease, so for example, an 80-year-old man who has come with dysphagia, weight loss, and the staging investigation has shown metastatic disease to the liver, the most appropriate treatment for them is a self-expanding metal stent, right? So they are not going to undergo chemo or surgery because these are all part of treating the patient with curative intent. Right, next is gastric cancer. So gastric cancer, most common, the general type of gastric cancer you'll see is adenocarcinoma. Again, patients can present with quite vague symptoms, including early satiety, weight loss. Sometimes if the gastric cancer is in the distal part of the stomach, it can obstruct the pylorus and cause gastric outlet obstruction. In staging gastric cancer, you don't require a PET scan generally. Some units would do it, but it's not standard of care. but you do require a CT, thorax, abdomen, pelvis to see for any distant metastatic disease. Sometimes EUS can be done again to look at the local staging, the depth of invasion of the tumor in the gastric wall and local lymph nodes. But laparoscopy is required for gastric cancer because the CT scan cannot pick up peritoneal metastasis. And a lot of the times you laparoscope a patient and you find that they have diffuse peritoneal metastasis or ascites. So treatment for gastric cancer, again, for advanced gastric cancer that is T2 and has nodes positive, will involve neoadjuvant chemotherapy. The most common type of chemotherapy now used is FLOT regime, which includes 5-fluorouracil, leucovorin, oxaliplatin, and a taxane. But I don't think you need to remember the names of the drugs. And then the surgery depends upon where the tumor is located. So if it is a distal tumor, a distal gastrectomy can be performed. If the tumor is proximal, then a total gastrectomy is usually performed, with both of them with a Roux-en-Y reconstruction. So a distal gastrectomy would involve a gastrojejunostomy, a Roux-en-Y gastrojejunostomy reconstruction, and if a total gastrectomy is performed, it would involve an esophagojejunostomy with a Roux-en-Y configuration. The role of radiotherapy in gastric cancer is quite limited. However, sometimes, for example, you've done a distal gastrectomy for a patient who presented with gastric outlet obstruction due to cancer, and they have advanced disease, node positive disease. People can have radiotherapy in the adjuvant setting, which means after the operation, but the role is limited. Right, so the next topic, so as I said, I'm going to quickly go through these topics and then you can ask me questions at the end. So the next topic is Barrett's. And again, a lot of questions I saw on the website from Barrett's esophagus. As you know, Barrett's is the result of metaplasia, and metaplasia means that one adult epithelium is changed into another type of adult epithelium. So the squamous epithelium of the esophagus is changed into small intestinal mucosa with goblet cells. So it is important to remember this. When a gastroscopy is performed, it is reported what we call, according to Prague classification, which measures the maximum extent of Barrett's and the maximum circular extent of Barrett's. And then we report it as in centimeters. As I've mentioned earlier, if the initial insult, so Barrett's usually results from reflux of acid and bile. And if that is left alone or is not treated, then over the years, the metaplasia can change into dysplasia, low-grade dysplasia, followed by high-grade dysplasia, and high-grade dysplasia amounts to carcinoma in situ, which can then change into invasive cancer. So treatment of Barrett's, so if it is non-dysplastic Barrett's, then you just need to treat it with PPIs, right? So to prevent acid reflux and educate the patient about reducing their weight, to stop smoking, stop drinking alcohol, keep the head end of the bed elevated, not to eat close to going to bed, all the general measures that can be done to reduce reflux. But if you have and then the surveillance now for non-dysplastic Barrett's is you could do an OGD between 3 to 5 years. However, if there is dysplasia, so the Barrett's needs to be biopsied, and if the biopsy shows dysplasia, then in case of low-grade dysplasia, it needs to be monitored more frequently, 6 monthly. But in case of high-grade dysplasia, that needs to be treated, and that can be done with EMR. So if the high-grade dysplasia is localized, you do endoscopic mucosal resection to remove that part of the mucosa and examine it under the microscope to see the depth of invasion. If it is high-grade dysplasia that is confined to the mucosa, then that's enough. You don't need to do anything further. However, if you find that the tumor is already invasive and going beyond the submucosa, then the patient will ultimately need an esophagectomy. Once you have done EMR for high-grade dysplasia, the rest of the Barrett's needs to be treated with radiofrequency ablation, and you might require more than 1 sessions of RFA. Right, so now we move on to more benign things. So gastroesophageal reflux disease, very common. You'll see it commonly in your clinical practice. Most patients present with heartburn, sometimes atypical chest pain, can also present with, recurrent aspiration pneumonias or coughing at night. And diagnosis is again usually with endoscopy. You might see esophagitis. The esophagitis on endoscopic appearance is then described according to Los Angeles classification, but I think you don't need to go into the detail of that. Primarily treated with medical therapy, previously was treated with ACE2 receptor blockers like ranitidine, famotidine, but they are out of fashion now, and it's being treated with omeprazole or esomeprazole, the PPIs. If we are planning for an anti-reflux procedure surgically, then we always look for pH and manometry studies. So manometry tells you the pressures in the esophagus. So essentially what is done is that, just like an NG tube, a pressure transducer is introduced into the esophagus. So it has transducers all along. And then you ask the patient to take 10 wet swallows. So they drink 10 sips of water. And the transducers measure the pressures in various parts of the esophagus. So it will help to tell us whether there is any motility disorder of the esophagus, because doing a anti-reflux procedure where there is significant motility disorder can result in dysphagia and can not improve the symptoms of the patient. So that's important. And again, you don't need to go into the detail of that, but maybe you should know that once manometry is done, the findings are classified with what is called as Chicago classification. So the Chicago classification then tells you whether the patient has achillesia, what type of achillesia, or whether they have nutcracker esophagus or jackhammer esophagus. So just to keep in mind that there is something known as Chicago classification, which helps us diagnose the motility disorders of esophagus based on manometric studies. And the pH studies, there is pH monitors that are again introduced into the esophagus, and they are left for 24 hours with patients doing their normal activities, usually done off PPIs. And in the end, on the report, you get, various figures, how many times the pH in the esophagus went below 7 or, was acidic, whether the patient was lying down or upright when the reflux occurred. And it also gives you a score, which is called as Demeester score. And the normal Demeester score is about 14. So generally, patients who have bad reflux would have high Demeester score of 30, 40, or maybe even higher. And the surgical options for treatment, they include fundoplication, which means that you wrap the fundus of the stomach around the esophagus to reinforce the lower esophageal sphincter. And fundoplication can be of many types. It can be a 360-degree fundoplication called Nissens, or there are various others where you don't wrap the entire esophagus. The next most important topic that's frequently asked is achillesia. Achillesia is a motility disorder of the esophagus, which is characterized by hypertensive lower esophageal sphincter, which fails to relax. as well as ineffective peristalsis. Okay, so both these things are important. A hypertensive lower esophageal sphincter that fails to relax and ineffective peristalsis. And as I said, diagnosis, so the gold standard or most appropriate investigation to diagnose is high resolution manometry, which then you can classify according to Chicago classification. Treatment of Achillesia can involve pneumatic dilatation. So there is a special Achillesia balloon that you can dilate that you can put at the level of the OG junction, insufflate, and that will cause disruption of the lower esophageal sphincter, right? Or you can perform laparoscopic Heller's cardiomyotomy. So you divide the muscle coat of the esophagus, and just the mucosa and submucosa will bulge out. And more recently, peroral endoscopic myotomy, known as POEM, is being done, and the results are comparable to pneumatic dilatation or cardiomyotomy. However, whenever you are doing a Heller's myotomy, you always perform an anti-reflux procedure with it, whereas with POEM, you can't do that. So patients tend to have more reflux or heartburn symptoms after it. And then for people who are not able for any of these treatments, Botox injection can be given that will paralyze the lower esophageal sphincter and give symptomatic relief. But Botox will only last for 3 to 6 months, and then it would have to be repeated. So Botox is not the first line treatment for Achillesia. It's only done in people who are not suitable for anything else. Right, so we move on, peptic ulcer disease. So if a gastric ulcer is seen on a gastroscopy, it must be biopsied, and then a repeat endoscopy is usually done to ensure that it is healed, because you cannot leave a gastric ulcer without without a diagnosis, because consider gastric ulcers as malignant until unless proven otherwise. And what you see here is CLO test. So whenever you're doing a gastroscopy, you take a small biopsy and put it on this rapid test. So this is a rapid urease test. Basically, it is testing for the urease enzyme that H. pylori produces. And if it is positive, it turns pink. So CLO means Campylobacter-like organisms, because H. pylori was like Campylobacter, and that's how it was first discovered. But so it's called CLO test, but it is done for H. pylori, and it is detecting urease enzyme in that. You have to take a small biopsy to put on that. And if it does turn positive, then you need to treat, and you will treat it with triple therapy. Triple therapy usually involves amoxicillin, clarithromycin, and PPI. But there are different forms of triple therapy. It could also be clarithromycin, metronidazole, and PPI. Usually PPI is the triple therapy is given for between 7 to 14 days, but PPI is continued for 6 weeks. Before the advent of PPIs, because the peptic ulcer disease, distal gastric ulcers, enteral ulcers, they were more common. They led to scarring and fibrosis, gastric outlet obstructions. So a lot of surgery was done for that. But with the advent of PPIs, we don't see complicated ulcer disease that commonly, and those surgeries have gone out of fashion. So then we have next, obviously, duodenal ulcers. And duodenal, a common acute emergency that we still see with duodenal ulcers is perforated duodenal ulcer, and this can very well appear in your exam. A young smoker, for example, presenting to the emergency department with severe abdominal pain that started in the epigastrium, then spread all over, will have peritonitis on exam, on abdominal exam. So what you need to do is first of all, do your sepsis 6, ensure that you are resuscitating the patient, giving him IV fluids, antibiotics, oxygen, checking their lactate, general bloods, urine output, etc., etc. And this is the pathogenomic or the book picture of perforated DU, where you see the air under the right diaphragm, free air under the right diaphragm. Now, this just means that one of the hollow organs in the abdomen has perforated, but it's most commonly seen with perf DU. And the operation requires thorough washout of the peritoneal cavity and repairing the perforation. So most commonly performed repair is called gram patch repair, where you put an omental plug over the ulcer. And this can be done open or laparoscopically. The other problem that we see is upper GI bleeding, which one of the causes could be an ulcer. It could be a gastric ulcer, or more commonly a duodenal ulcer. And what happens is that if the ulcer is on the posterior wall of the duodenum, it erodes into the GDA, the gastroduodenal artery, and causes massive bleeding, right? The other causes of upper GI bleeding, as you know, can be varices, esophageal varices or gastric varices, Mallory Weiss tear, tumors, esophageal or gastric tumors. So they're the common things. And always remember, the first step is resuscitation. So you need to give the patient fluids, you need to replace their blood, remove any, treat any underlying cause if you can. And then the first line of treatment is endoscopy. You can put endoscopic clips to control the bleeding. You can inject with adrenaline. You can use gold probe to diathermy the vessel. This is not true for varices. For varices, you will have to band them or inject cyanoacrylate glue. If endoscopy is not successful, or despite the endoscopy the patient has rebled, you can get the interventional radiology colleagues to embolize the GDA, especially in case of posterior duodenal ulcers. And then surgery is the last resort. If nothing works, you can open the duodenum, do a pyloromyotomy, and underrun the vessel. Right. So next is, I'm just coming to the end now, really. These are last few slides. So definitely now you will get some questions regarding bariatric surgery, because it's becoming more and more common. While working in any specialty, in any acute specialty, you'll come across patients having these troubles. So we see a lot of gastric bands were being done previously. The less of them are being done now, and about 50% of bands end up being taken out at 10 years post insertion because of complications. So the most common problem patients present with is symptoms of gastric outlet obstruction. So dysphagia, vomiting, can't tolerate anything, sometimes epigastric pain. And what happens is that the gastric band has slipped. So it actually means that the stomach that was supposed to be below the band has slipped up through the band and can start to become relatively ischemic. So it can be easily diagnosed on a plain X-ray. So the band should lie, this angle is called angle of phi or phi, and it should lie between 4 and 58. So that's how you should see the band. If the band is more horizontal, that means that it's slipped, right? And you should not be able to see the circle of the band. So you should just be able to see the side of the band like this. So if you are seeing a full O, or you are seeing that the band is lying kind of fully horizontally, that means that the band has slipped. And the first thing is to deflate it. So you require a Huber needle, which is kind of like a blunt needle that oncology also use for accessing porta cats, but the Huber needle is much longer. So you determine where their port is. It's usually in the epigastrium or the left upper quadrant, and you take out the fluid that's in the band. If that doesn't work, then ultimately these bands need to be removed laparoscopically. The other thing that's being seen in surgery now is internal hernias after gastric bypass surgery. So especially after a Roux-en-Y gastric bypass, there are a number of places where patients can develop hernia. So it can be at the level of where you've performed the jejunal-jejunostomy, so between the mesentery of the two jejunums. So we usually stitch it closed, but as patients lose weight, the fat dissolves and sometimes these spaces can open up again. So that's one site of hernia. The second site is if you've done a retrocolic, and same after if the patient's had a total gastrectomy, if you've done a retrocolic elementary limb, it can occur through the transverse mesocolon. But usually now we are doing anticolic, so we come in front of the colon. We come in front of the colon, but still there is another space called as Peterson's defect, which is between the mesentery of the elementary limb of the jejunum and the transverse mesocolon. So that space we also close generally, but still sometimes these hernias can occur, the spaces can reopen. And if that happens, usually patients will present with severe abdominal pain. And because it's usually the biliary limb that herniates, they might not have the typical signs and symptoms of small bowel obstruction. So they might not be vomiting as such, and plain film abdomen might not show dilated loops of bowel like it does for a routine small bowel obstruction. So if a patient who's had previous bypass presents with severe abdominal pain that's out of proportion to the clinical signs, always think about an internal hernia causing small bowel ischemia, right? So involve your seniors quickly and have a low threshold to laparoscope. Again, CT is not very good at diagnosing these either. So I think that should be my last slide. So we've just kind of sprinted through all the topics. So now you have plenty of time to ask questions.
All right. So if anybody has any questions, they can type the questions in the chat box, or they can speak now as the lecture is over.
That's good. I'm glad. No questions.
No,
and I'm sure all of you must be doing some MCQ banks and things. So if you have come across any upper GI questions that are not clear or you want to clarify, you're most welcome to ask.
It's just the way you delivered the lecture, it was very simple and just related to MRCS part A. So it was very good.
Yeah, so again, if you go into too much unnecessary detail, the questions are MRCS exam is meant to be at an SHO level. So, and you obviously require knowledge of all the surgical specialties. So there is no need to dwell into too much detail about anything because they haven't made the questions for that purpose. And if you know too much about a topic, then you can actually feel confused when you're looking at the options.
Mm-hmm. There was a question he wanted to ask: are we tested around surgical procedures a lot in MRCS part A?
No, very little.
Very little. All right.
Yeah, nobody is going to ask you, the steps of anything,
Mm-hmm. No. So I think there are no further questions. So thank you so much.
Yeah, no problem, no problem. Yeah, thank you very much for
Thank you so
inviting me.
much.
Okay, that's very good. If no
Thank you.
questions, then we'll head off. And yeah, thanks very much for arranging that, Tala.
Thank you very much. Thank you.
Okay, bye
Thank
now.
you. So we're going to send you this video recording through via your emails. We're also going to send you the feedback forms on the email. So kindly fill out the feedback form so that we know how we can improve. And we will be back next Thursday, 6 p.m. UK time. Thank you very much. Thank you.
Okay, bye.